A very good morning to all of you. I'll be discussing the procedure called SMILE or Small Incision Lenticular Extraction, which is possibly the next leap in refractive surgery that we are going to see. As we have discussed, in the conventional LASIK, the microkeratome is used, and in the blade-free LASIK, the femtosecond laser is used to create a flap. What is unique about the SMILE technology is that it does away with the flap and possible risks of flap-related complications. How it does so is that it uses the femtosecond laser instead of the excimer laser to perform the refractive correction. The femtosecond laser is perhaps the greatest cutting tool that we have on our hands in today's ophthalmic world. This femtosecond laser carves out a refractive lenticule within the corneal stroma, which can then be extracted from a tiny incision side cut, unlike the flap that is required for a LASIK procedure. This is because the excimer laser is a photoablative procedure, is a laser, and has to act on a surface. Therefore, you need to lift a flap and give it the bare stroma to a blade. The femtosecond laser, working on the principle of photodisruption, has the ability to act below the surface. These subsurface effects allow it to create a lenticule within the cornea without the need to give a flap creation. Therefore, if you obviously don't have a flap, you will not be seeing all this. Any flap-related fiasco has to go. In comparison to the excimer laser, the femtosecond laser also has the advantage of being a solid-state laser and therefore is relatively immune to environmental factors such as humidity. This possibly leads to stabler refractive corrections when you're using a femtosecond laser for refractive correction, unlike the excimer laser. Now, though there are about half a dozen femtosecond lasers available today, there is only one that at present has the ability to perform SMILE, that is the Visumax system from Carl Zeiss. Why that is so is because not only does it have a precise way of delivering energy in a high frequency with a high numerical aperture, it also differs from other femtosecond laser in the patient interface. The patient interface that it uses is a curved contact glass interface. This interface does not aplanate the cornea. Now, if the cornea was a perfectly elastic structure, as you can see in this, it would, in a sense, be aplanated well, but because of its not perfect elasticity, if you aplanate it, you tend to distort it. And if you are making precise incisions in a distorted corneas, you will get distorted outcomes. Therefore, this curved contact glass interface works on a near normal anatomy, undistorted anatomy of the cornea, and allows you to create these precise cuts. This lenticule, which is going to be created, is going to give you the refractive correction. The 4 cuts that are prepared by the femtosecond laser, the line in green is the posterior surface of the lenticule. The diameter of this will correspond to the optical zone of correction that you will get. The red line shows you the lenticule side cut. The blue line is the anterior surface of the lenticule or the cap, which overrides the posterior surface on either side. This small line in orange is the side cut through which this lenticule will be extracted. Now, the gap between the green and the blue line, or the thickness of the lenticule, will correspond to the refractive error that you need to correct. The higher the refractive error, the thicker will be the lenticule. Even if you're correcting higher refractive errors, the passes would roughly be the same. It's only the lenticule thickness which would vary. So even with high refractive corrections, you have a sub 30-minute treatment time, 30-second treatment time. At present, the femtosecond laser with the SMILE system can correct up to 10 diopters of myopia and 5 diopters of astigmatism, and a spherical equivalent of 10 in the present software, but with the software upgrade, it will correct a spherical equivalent of up to 12.5. It is not for use in hyperopia as of present day. Just to showcase the procedure in a surgical video, this is a green blinking light which is to be centered in the center of the pupil, allowing you to have a central correction and creation of the lenticule. The use of the infrared technology in this system allows you to center it better on the pupil. Now, you saw the posterior lenticule pass, the anterior lenticular pass, and this is the side cut which has been created. This system has an integrated surgical microscope, so the patient is just moved backwards and you now have a good surgical view. A sharp dissector is to delineate the side cut. Remember, it is important to first separate the cap from the anterior surface of the lenticule and then move behind to separate the posterior surface of the lenticule from the corneal stroma beneath. This makes the flap extraction much easier. If you do it the reverse way, you risk the flap getting stuck upwards and the extraction becomes more difficult. A blunt spatula which curved to mimic the curvature of the cornea is then put in to dissect the entire plane. This is the dissection of the cap from the anterior surface of the lenticule. We then move back towards the posterior plane. This is the posterior surface of the lenticule being separated from the underlying stromal bed. Once the dissection is completed, this lenticule can be extracted through this small side cut incision that you see. This can vary from 5 to 3 millimeters. This is a 3 millimeter side cut that we're using. The microforceps is then used to hold the lenticule and the lenticule is pulled out. And this is the end of the surgery. Now obviously when you're not creating a flap, you are doing a small side cut, you will have other advantages as well. You will be severing less corneal nerves and the potential for dry eye is much less in these patients. You will perhaps be having a better biomechanics that you're going to be leaving behind because the side cut is known to weaken the cornea to a great deal. In our study, which was carried out under Dr. Rupal Shah at New Vision Laser Center, Center for Sight, in 25 patients, a contralateral eye study comparing SMILE with femtoLASIK was done and the outcomes of both were comparable. In the initial week, sometimes with the femtoLASIK, the uncorrected visual acuity may be better, but within the first month, SMILE overtakes LASIK in terms of the visual outcome of the patient. Another possible advantage which has been highlighted by Dr. Dan Reinstein is the fact that SMILE leaves the cornea biomechanically best. Now, when you are doing a PRK, you are ablating the anterior stroma, which is, we all know the anterior 1/3 of the stroma is the strongest part of the cornea. So you are ablating the strongest part. When you're creating a flap, we all know that the flap does not contribute to the biomechanics anymore, so you're losing a large contribution to the corneal stroma. In SMILE, since you're not creating a flap and you can remove the lenticule from the anterior or mid stroma, you're just removing a lenticule corresponding to a tissue loss in PRK, but because it is from a more posterior part, possibly the biomechanics of a cornea post-SMILE will be better than that post-PRK and post-LASIK. Though SMILE is a preferred procedure, it does have a distinct learning curve, which comes in both docking as well as in dissection. This is just a small complication that I'm showing you. This is within docking, the patient moves and we lose suction. So once suction is lost, you don't have much to fear because the femtosecond laser is much more forgiving and you can just redock and complete the procedure. This is just the anterior pass which was left incomplete. We redock and just redo that and then the lenticule is extracted as I showed you before. A concern for patients for SMILE was the fact that a re-SMILE cannot be done. So what about the enhancements that you have to do? One option is to do surface ablation, that is a PRK. But now with this new software, you are also able to convert the SMILE to a LASIK procedure. The circle scan offers you the option to create this cap into a flap. So with this junction cut, this planar cut and a side cut, this can be converted into a flap, just this last video. So as we see here, this is a patient operated for SMILE. We have fortunately very less retreatment rates for SMILE, but just to so this is the way the software works and creates this circle scan, and when you lift it, you have a stromal bed like you have in LASIK and you can do the enhancement and put the flap back on. Since this is a fresh flap, you don't risk epithelial ingrowth and other complications that you have with a re-lift of a flap, and therefore makes not only the SMILE procedure but also the retreatments much safer. I'd like to summarize by saying that SMILE is perhaps the next leap, and in near future we may see it race ahead of the conventional and the blade-free LASIK for myopia. Thank you for your attention.
Thank you, Dr. Ritika. This was